Greetings and welcome. My name is Joe Macbeth, and I'm the President and CEO of the National Alliance for Direct Support Professionals. And welcome to today's installment of our update on the COVID-19 pandemic, what we know, what we think we know, and what we'd like to know. I'm so happy to be here with our National Medical Advisor, Dr. Rick Rader. Dr. Rader has been kind enough to do these types of updates specifically for direct support professionals throughout the course of this pandemic. I think this is probably the 5th or 6th webinar that Dr. Rader has done with us. Everyone is different, obviously. We've got different information. There's new information to share with you. And this is going to recap all of those things. But before I begin, I also want to congratulate Dr. Rader. He's recently been appointed to the National Committee on Disabilities, the National Council on Disabilities, by the President. And that is a huge deal. And I'll tell you why. There probably is not a better advocate for direct support professionals in the medical community than Dr. Rader. So Dr. Rader, congratulations to you. Please never forget what direct support professionals do for people with disabilities in their health and their dental health. So take it away.
Okay, well, thank you very much, Joe and John. And want to thank you for the opportunity to present in this update on COVID-19 and its impact specifically on DSPs. The reason that we needed and you deserve this update is the reason why updates exist in the first place. And that's because the news, the understanding, the experience, and the long-held beliefs change. And in the case of COVID-19, they change at a very fast rate. And sometimes it's not just a change in a few degrees, sometimes it's 180 degrees. And that's when it impacts on your role, your practices, and your profession. When we first presented on COVID-19 to DSPs, it resulted in the largest number of DSPs who registered and attended the session, more so than any other topic offered by the NADSP. And it's no surprise because this is high stakes poker. And I don't hesitate to use the imagery of poker because without the facts or with the facts that change regularly, it's almost like gambling. We're betting on the information to be reliable, accurate, authentic, and factual. As we have learned, that has not always been the case. I wish I could say, okay, the coast is clear, we won, the virus is heading out to sea, but it's not that kind of storm. It's here, and it appears it will remain here, and we have to process, interpret, and employ that which we know, that which we wish we knew, because we're certainly not going anywhere, and we have to live with anything and everything that nature has decided to throw our way. Every day my inbox receives hundreds of emails, mostly medical and health related. I can barely keep up with it. I'm going to share pieces of information that I have collected over the last few weeks that I think is valuable to DSPs, hopefully in simple to understand concepts that you can begin to use starting tomorrow. So a little bit of an overview basically is the United States leads the world in cases of COVID-19. Since the COVID-19 pandemic began, the number of unexpected or excess deaths over the typical number has risen 20%. From March 1st to August 1st, over 1,300,000 deaths occurred in the US, which is about a 20% increase compared to the number of expected deaths. About 2/3 of these excess deaths were attributable directly to COVID, while deaths attributed to other causes could have been related to the pandemic in general for all of 2020. This could translate into 400 related deaths beyond the 200,000 that we know specifically from COVID. Researchers compared COVID-19 deaths and excess deaths from all causes in the US with those from 18 other countries with a population over 5 million. Among the 15 countries with moderate mortality or high mortality, the US ranked 3rd. Researchers define moderately mortality as 25 deaths per 100,000 people, and high mortality to more than 25 deaths per 100,000. The US has 71.6 death rates per 100,000 people. Basically, this suggests that for the entirety of 2020, more than 400,000 excess deaths would occur. And again, excess means deaths that typically are not necessarily calculated. For every COVID death, about 9 family members are affected, suffering with post-traumatic stress disorder or prolonged grief. That translates to about 3.5 million people in the US who could develop major mental health needs. The pandemic poses the greatest risk to prosperity and well-being since the Great Depression in 1929. Costs including lost economic output and losses related to health may approach $16 trillion. One of our major concerns is that small gatherings in people's homes are becoming a larger source of coronavirus transmission. We're seeing the increasing threat right now is actually acquisition of infection through small household gatherings. Think group homes. With Halloween, Thanksgiving, and other holidays coming up, these gatherings could become a major concern. We think it's really important to stress the vigilance of these continued mitigation steps in the household environment. The 7-day average for new U.S. coronavirus cases passed 51,000 on Tuesday, making for the first time in 2 months that the number crossed the 50,000 a day mark. In addition, more than 36,000 COVID-19 patients were in hospitals across the country on Tuesday. That's the highest number since late August. This virus can spread among families and among friends if you take your mask off and are primarily indoors. When in private, we need to take the same precautions that we take in public. This could mean producing a safe space for vulnerable family members to sit and interact at a distance and wearing masks inside the house. While eating without masks on, family members may sit further apart to prevent the spread of the virus. Respiratory viruses tend to be seasonal, including the two most common flu viruses, but the coronavirus that causes COVID-19 seems to be a year-round nuisance. Environmental factors such as humidity and temperature don't appear to affect the coronavirus as much as other viruses, which flourish more in the dry, cold months of winter. Coronavirus transmission can still happen in warm and humid places, as seen in the US during the past summer months. For now, the study authors suggest that people continue to wear face masks and follow social distancing guidelines, since most people have still not been exposed to the coronavirus worldwide. According to Johns Hopkins University, there are more than 38 million cases and more than 1 million deaths worldwide. More than 26 million people have been recovered. There are more than 7.8 million cases in the US of COVID-19 and more than 250,000 deaths. More than 3.12 million Americans have recovered from the disease, according to data that we have. Basically, that is sort of like an orientation to what things are looking like, is basically what we see. What's new and not surprising is that people with developmental disabilities who live in group homes have some of the highest death rates from COVID-19 in the country. How's this for a wake-up call? They're more likely, you're more likely, 4 times more likely to actually contract COVID-19 than the general population. And then if they do contract COVID-19, if they're about 2 times more likely to die from it. But that's just the big picture. Of those who survive, we're expecting to see long-term consequences to virtually every body system. It's not simply anymore a respiratory disease. It affects the heart, brain, blood vessels, digestive system, and the immune system. We are not certain to what extent and for how long, perhaps for a lifetime. Some people use the terms quarantine and isolation interchangeably, but they're not. So what's the difference? Quarantine is used to keep someone who might have been exposed to COVID-19 away from others. Quarantine helps prevent spread of the disease that can occur before a person knows they are sick or if they are infected with the virus without feeling symptoms. Quarantine or isolation, what's the difference? Quarantine keeps someone who might have been exposed to the virus away from others, while isolation keeps someone who is infected with the virus away from others, even in their own home. So who needs to quarantine? People who have been in close contact with someone who has COVID-19, excluding people who have had COVID-19 within the past 3 months. People who have tested positive for COVID-19 do not need to quarantine or get tested again for up to 3 months, as long as they do not develop symptoms again. People who develop symptoms again within 3 months of their first bout of COVID-19 may need to be tested again if there was no other cause identified for their symptoms. So what counts as close contact? If you were within 6 feet of someone who has COVID-19 for a total of 15 minutes or more, if you provided care at home to someone who was sick with COVID-19, if you had direct physical contact with the person, hugged or kissed them, maybe you've been sharing eating or drinking utensils, maybe they sneezed, coughed, or somehow got respiratory droplets on you. The steps to stay are to stay home and monitor your health, Stay home for 14 days after you last contracted with a person with COVID-19. Watch for fever, 100.4, cough, shortness of breath, or other symptoms of COVID. If possible, stay away from others, especially people who are at higher risk for getting sick from COVID-19. The CDC has new guidelines for patients quarantined due to coronavirus. The guidelines say most adults who have mild to moderate symptoms can stop quarantining after 10 days. It also says that they do not need to be retested before returning to work. The latest scientific data shows most people are no longer infectious 10 days after their symptoms begin. Most adults who have had mild to moderate COVID-19 illness can now leave isolation after completing 10 days in home isolation, and persons do not need to be retested before returning to work. As the medical community better understands how people are infected and transmitting the virus, another significant change is that retesting is no longer recommended in order for most patients to discontinue isolation. Additional revisited CDC guidelines include the following. If COVID-19 patients have had a fever, the recommended number of hours that have passed since their last fever without the use of fever-reducing medications is now reduced from 72 hours to 24 hours to discontinue isolation. Asymptomatic persons can discontinue isolation and other precautions 10 days after the date of their first positive SARS test. For persons who have been diagnosed with symptomatic COVID-19 and remain asymptomatic after recovery, retesting is not recommended within 3 months after the date symptoms begin to the initial COVID infection. For persons who never developed symptoms, the date for the first contact of the test should be used as the place of the date for symptoms created to determine length of isolation. The current rise in coronavirus cases around the U.S. is reminiscent of the summer crest and has flashbacks to the emergence of the national crisis in spring. There are attempts to characterize what's happening, a third wave or a third peak of a single wave that never fully ebbed. But whatever your semantic preferences are, cases are racing up in many states and breaking daily records in the Midwest and Mountain West. They're even creeping up in places that experienced the brunt of the earlier outbreaks, like Massachusetts and New York. Experts have warned that the country needed to take steps at the end of the summer and the beginning of the fall to make headway in suppressing its infection rate. They expect transmissions to pick up as temperature drops and the winter arrives. But because of behavioral changes, people spending more time indoors and having contact with more people, and because they anticipate that the virus will spread even more efficiently in cold, dry weather. Instead, cases have gone in the other direction, already starting to increase and portending even more dire months ahead. 7 months into the eye of the U.S. epidemic, people are tired of the precautions meant to slow the spread of SARS, the virus that causes COVID-19, but slip-ups and relaxed attitudes are in turn driving new illnesses. The fundamental transmission of the virus hasn't changed. The virus will go where it's given room to run and will find people who are susceptible. Despite over 8 million confirmed U.S. cases, the vast majority of Americans, up to 90% according to federal estimates, remain vulnerable to an infection. Last week, the country hit 70,000 daily cases for the first time since July. The new climbing cases also started from a higher point than the summer peak. With more virus circulating, it's more likely that some cases will spark new chains of transmission or that super spreading events will occur. So the CDC is not the only medical group that has changed some of their guidelines. Let's look at the World Health Organization. The World Health Organization basically urged world leaders this week to, quote, stop using lockdowns as your primary control method. The World Health Organization does not advocate lockdowns as the primary means to control this virus. Quote, the only time we believe a lockdown is justified is to buy you time to reorganize, regroup, rebalance your resources, protect your health workers who are exhausted, but by large, we'd rather not do it. They really want to appeal to all world leaders to stop using lockdown as their primary control method. Earlier this week, thousands of medical health experts signed their names to a petition calling for the end of coronavirus lockdowns, citing, quote, the irreparable damage they've caused. It's called basically the Great Barrington Declaration, and it basically is advocating for the removal of these lockdowns. In the United States, lockdowns have been tied to increased thoughts of suicide from children, a surge in drug overdoses, an uptake in domestic violence, and a study conducted in May concluding that stress and anxiety from lockdowns could destroy 7 times the years of life that lockdown potentially saves. So the other thing is that the United States had prevented or delayed about 530 million COVID cases, along with China, South Korea, Italy, etc. So how do you verify and how do you balance, the negative consequences of basically staying indoors versus basically returning to a normal life? In this open letter called the Great Barrington Declaration, lockdown measures are doing more harm than good, and we should open up society and let the virus rip, according to these epidemiologists. But that's a bit of an exaggeration. The declaration, named after the US town where it was signed, advocates a strategy called focused protection, under which the most vulnerable people shield and everybody else should immediately be allowed to resume life as normal. This will then allow herd immunity to build up. The declaration publicly exposed a scientific disagreement that has been simmering for months. On one side are mainstream scientists who are reluctantly see restrictions as freedom as the only way to keep a lid on the pandemic while we wait for vaccines. On the other, the libertarians who see the damage done to economics and individual lives as too high a price to pay. Herd immunity is conceptually simple. If enough people become immune to an infectious agent, the entire herd is protected, because infectious people rarely encounter a non-immune person, and so transmission fizzles out. The level of individual immunity required to obtain herd immunity depends on how infectious the virus is, as measured by what's called R, the average number of people that each infected person infects. The classic example is measles, which has an R number of around 15 and a herd immunity threshold of 95%. The numbers for the corona SARS virus are about 3.5 and 60 to 70%. Herd immunity has only ever been attained by vaccination, but the declaration advocates natural acquired immunity. In other words, letting between 2/3 and 3/4 of the population catch the virus. There are a number of issues with this, not at least collateral damage. Even if the death rate is under 1%, letting the virus run free will hospitalize and kill millions. But there was another crucial scientific detail that the declaration, along with most discussions of herd immunity, misses. We can't take it for granted that widespread individual immunity will automatically create herd immunity. Herd immunity can only be built if the immune response totally prevents individuals from picking up and transmitting the virus. That sometimes happens, but often doesn't. A lot of the time, an immune response stops us from falling ill if we reacquire the virus, but doesn't prevent onward transmission. The same is true of vaccines. We don't yet know whether natural immunity to SARS-CoV-2 or the experimental vaccines will halt transmissions. Until we do, assuming that herd immunity will automatically appear is unscientific and frankly irresponsible. Well, you might be asking, okay, Dr. Rader, that's interesting about the World Health Organization instructing countries not to use lockdowns as the primary strategy to control the pandemic. But I'm a DSP working in a group home in Ohio and New Jersey. I'm not the freaking prime minister of some nation, and you'd be right to ask that. But in a way, you are the prime minister of a country. At least it's a country to the 2 or 4 guys and gals who live with you. And if the pandemic lockdown are causing havoc, collateral damage to a normal way of life, including mental health issues, well-being, and social isolation, maybe you and your supervisors need to revisit your lockdown quarantine policies. At least start the conversation. Perhaps you are under the doctrine of state health department regulations and you can't lessen the lockdown mandate. But if you need to think of the idea of easing up on quarantines and lockdowns and evaluate all the factors and consequences of the lockdown, it might be of value when you consider the plus and minuses of the lockdown, because then you can more readily support the strict doctrines and perhaps even do a better job of explaining it to your folks. Even if the World Health Organization said that the first obligation is to protect the most vulnerable populations and apply the loosening of the lockdown to those who are less vulnerable, your voice as DSPs need to be heard. And of course, like all decisions, health and safety, however you define it, needs to be a major contributor to that decision. I'm simply saying that the decision makers should be inviting all the stakeholders to critical decision-making opportunities and DSPs have the inside track on the big picture. So we all know there's a race to develop COVID-19 vaccine. Typically, vaccines take 10 years to develop. The US government is fast tracking the process. The program is called Warp Speed. The term comes from Star Trek, where spaceships could travel faster than the speed of light. So that's more than 186,000 million miles per second. So that's fast. Vaccines typically require years of research and testing before researching the clinic, but scientists are racing to produce a safe and effective coronavirus by next year. Researchers are testing 45 vaccines in clinical trials on humans, and at least 91 preclinical vaccines are under active investigation in animals. Vaccines have to go through multiple stages to guarantee their safety and their effectiveness. Let me just walk you through the 4 different phases. First, we have preclinical testing, where scientists test a new vaccine on cells and then give it to animals such as mice or monkeys to see if it produces an immune response. Then we have phase 1 safety trials. Scientists give the vaccine to a small people to test safely and dosages, as well as to confirm that it stimulates the immune system. Expanded trials of phase 2 are where scientists give the vaccine to hundreds of people split into groups, such as children and the elderly, to see if the vaccine acts differently in them. These trials further test the vaccine's safety and ability to stimulate the immune system. And lastly, we have phase 3, the efficacy trials. Scientists give the vaccine to thousands of people and wait to see how many become infected, compared with volunteers who receive the placebo. These trials can determine if the vaccine protects against the coronavirus. In June, the FDA advised vaccine makers they would want to see evidence that vaccines can protect at least 50% of those who receive it. In addition, phase 3 trials are large enough to reveal evidence of relatively rare side effects that might be missed in earlier studies. China and Russia have already approved vaccines without waiting for the results of the phase 3 trials. We are not necessarily going to entertain using those vaccines. Regulators in each country review the trial results and decide whether to approve the vaccine or not. One way to accelerate vaccine development is to combine the phases. Some coronavirus vaccines are now in phase 1 and 2 trials, for example, in which they are tested for the first time on hundreds of people, etc. You can become a vaccine trial subject. If you're interested in volunteering for a COVID-19 vaccine, I can provide you sources. And that also raises the question, should the individuals we support be allowed to participate in vaccine trials if indeed they want to? Pfizer will expand its coronavirus clinical trials to include children as young as 12. It will become the first major vaccine to develop to beginning testing a COVID-19 vaccine in children that young. So what are the dangers of rushing the process? History has shown that vaccines developed or distributed in a hurry can lead to unintended consequences. In 1976, the US was dealing with a novel swine flu outbreak. President Ford's administration ignored a warning from the World Health Organization and vowed to vaccinate every man, woman, and child in the United States against the new virus. After 45 million people were vaccinated, researchers discovered a disproportionate high number of them, about 450 people, had developed Guillain-Barré syndrome, a rare disorder in which the body's immune system attacks the nerves, leading to paralysis. At least 30 people died. The WHO estimates vaccines, however, saved between 2 and 3 million lives. So basically, in Seattle and Atlanta, researchers plan to test animals and humans at the same time. Some vaccines can be mass-produced before the trials have even finished. We already know that some of the vaccine manufacturers have produced upwards of several 100 million dosage in the hoped-for expectation that the vaccines will be successful. As early as June, there were more than 120 candidate vaccines, according to the World Health Organization. This fast buildup basically is not cheap. The government already has given grants of $4.4 billion to pharmaceutical corporations. How effective or long-lasting will the vaccine be? If you get vaccinated against polio, you're probably protected for the life. But if you get a flu shot, you might still get the flu shot seasonal. and you'll need a different flu shot for next season. Researchers say at this point, there's no way to predict how effective or long-lasting a novel coronavirus would be. But like some vaccines, multiple doses might be needed to get the desired immune response. Are we sure we're going to get an effective COVID-19 vaccine? Absolutely not. While researchers are quite optimistic, there is no guarantee. I want you to all know, however, that the AADMD and other proactive advocacy groups have basically gotten assurance from the federal agencies that vaccines for DSPs and folks with IDDD are in the top tier populations to receive that vaccine. So that's very, very good news, finally, that you guys get the credit that you need as being essential healthcare workers. So it's hard to predict, but between 3 to 11% of the population will get the flu every single season. It's hard to know how COVID-19 will mix with the flu season that we're anticipating coming up. This fall, however, nothing can be more important than to increase the American public's decision to embrace the flu vaccine with confidence. The CDC recommends everyone 6 months and older get a flu vaccine every year. CDC basically has indicated that CVS stores and Walgreens now have that vaccine available for you. Doctors recommend that patients get their flu shots in late September or early October so protection can last throughout the flu season, which typically starts about March or April. The vaccine lasts about 6 months. What do you have to know about the 2021 season? To get a flu vaccine no later than the end of October. So basically, listening to this, it's time to go get your flu shots now. It's also important to know that individuals over 65 should get Fluzone high dose because it provides better protection against the viruses. So it's basically 2 scoops. Is the flu vaccine safe? For the most part, yes. Common side effects include soreness at the injection site, headache, fever, nausea, and muscle aches and pains. But there's probably only a 1 in a million chance of basically getting some neurological deficit. Will the flu vaccine help prevent COVID-19? Experts speculate any vaccine could hypothetically provide some protection against the virus, but there's little data that suggests that the flu vaccine can protect against the coronavirus, which causes COVID-19. We don't want to confuse people of that because there's simply no data. Flu vaccines prevent flu, and they're working on a coronavirus vaccine, but they're separate. A study in 2018 found that the flu vaccine reduces the risk of being admitted to an ICU with flu by 82%. Make no bones about it, the regular typical seasonal flu is quite dangerous, where more than 36 to 40,000 people a year die. So that's not something to sneeze about. The CDC said 2 types of vaccines are available for the 2021 season, the trivalent and the quadrivalent. Your physician, your healthcare provider will know which one to give, basically. So take the one that is available and is recommended. There's also a nasal spray instead of a shot. And basically after the swine flu pandemic in 2009, several studies showed that the nasal flu vaccine was less effective than the H1N1 viruses, etc. The other thing to consider is that since we're looking at respiratory diseases, anything that basically enters the respiratory system through the nose can mask those symptoms. They can just be local reactions to the nasal spray. And there are differences between the influenza and the COVID-19. A lot of the signs and symptoms are the same, but they can have varying degrees of intensity. Typically COVID-19, the signs and symptoms are much, much more severe. Both of them can cause mild to severe illnesses and common signs, including common signs and symptoms. Typically, a person develops symptoms 5 days after being infected with COVID-19, but symptoms can appear as early as 2 days after an infection and as late as 4 days. Most people with flu are contagious for about 1 day before they show symptoms and signs, etc. But we are very, very concerned about protecting each other against COVID-19 because of the high incidence that they have. So let's look at cleaners. You know, I go into group homes and I go into restaurants and I go into doctors' offices and I see very, very vigilant people spraying surfaces, etc. And they're using a variety of different different household bleaches, etc. So the number of common household cleaning products certified to kill the coronavirus, and that's specific to the coronavirus, continues to expand. Prior to this, since we didn't have the coronavirus, we had no mechanism to test the effectiveness, and they were basically assumptive. So this is quite interesting. The original Pine Sol was proven effective against the coronavirus after 10 minutes. It joins other Clorox brand products as well as several from Lysol on the EPA approved list. The active ingredients in the two Lysol products are quaternary, ammonium, and ethanol, but any products that have these ingredients should basically be effective. The EPA has a list of more than 400 products known as List N that are effective against viruses that are harder to kill than the one that causes COVID. So there is a high level of confidence that even though it wasn't specifically tested against COVID, since it's been tested on more difficult viruses, it can certainly be used. The two Lysol products are Disinfectant Spray and Lysol Disinfectant Max Cover. They were the first. They can kill the COVID in 2 minutes. Other chemicals in the products on the EPA's list include hydrochloric acid, hydrogen peroxide, sodium chloride bleach, and citric acid. It's very important to know that you should leave the product on the surface for at least 2 minutes before wiping them down to ensure they work. And why are clean surfaces so important? Public health experts believe that the virus mainly spreads from one person to another through respiratory droplets. They expel through coughing, sneezing, singing, and talking. These droplets may land on surfaces and they could infect others who touch them. The CDC says it recommends that people routinely clean and disinfect frequently touched surfaces. We're talking about keyboards and phone screens. They're also very possible sources of the virus. People are cleaning more during the crisis, but a third of them are using disinfectants that are unsafe to use. And basically they spray and they wipe and they're not basically removing that. So basically the EPA says follow the product's directions. You should also, it's important, pre-clean the surface before applying the disinfectants. These disinfectants do not work through dust, and so it's important to pre-clean the surface. It's also important to leave the product wet on the surface for the recommended time to make sure it effectively, usually 2 to 4 minutes. Do not just spray and wipe. You're wasting your time and giving yourself a false sense of security. Wear disposable gloves and wash your hands, and lock the cleaners away out of individuals' reach. And don't mix the cleaners. That might seem harmless, but it could create dangerous fumes. And at the end of the day, do not be afraid to use soap. And do not make cleaning solutions from bleach. So how long basically do these critters last? And this is kind of new and this is kind of interesting. The coronavirus can remain on some surfaces for 28 days, including phone screens, paper money, and stainless steel. The study by the CDC found that the virus can survive longer at lower temperatures and tended to last longer on non-porous or smooth surfaces, such as glass and stainless steel, rather than porous or rough surfaces, such as cotton. Temperature is a very, very significant player. Around a room temperature of 68 degrees, the coronavirus could last for 28 days on smooth surfaces. At higher temperatures, the survival time decreased as the temperature increased, and on cotton, the virus wasn't detectable after 14 days. However, the study was conducted in the dark to remove the effect of UV sunlight, which can inactivate the virus. That means the lab conditions may not match the real world. The items were left undisturbed as well, but phone screens and banknotes are often moved around, which could wipe off the virus. What we're seeing empirically, clinically, with contact tracing is that COVID is not spreading heavily through touch, although it certainly is worth our time to do a diligent job of cleaning. So sunlight, with the lockdown, basically we're not getting outside, and basically not being outside has a lot to do with not being exposed to sunlight. And as you know, sunlight for many of us is a panacea. Going out into the sun not only means you're going to be impacted by the sun UV rays, etc., but it means that you're probably going to be basically trying to get back to normal. seeing things that are familiar and basically sympathetic to you, possibly meeting people, seeing people, possibly getting some exercise. So it's not just the sunlight basically that we're looking to go after. It's basically everything that happens to us as individuals when we're in the sun. Many of us now spend up to 90% of our lives indoors, and our retinas are bombarded with artificial light late in the evening. Again, very, very important to understand that it can reduce risk of type 2 diabetes, it boosts your immunity, it certainly reduces certain cancer risk, it can lower your blood pressure, it improves your eye health, it can certainly cure depression and anxiety, etc. And basically try to get as much sun as you can, especially it's going to get a little more difficult now as the seasons change and the days become shorter. So maybe you want to get your sunlight in the peak, and that's in the morning too. So let's not forget, you know, the need to get some sunlight. So I love this topic. On top of everything the DSP is determined and required to do, and at a time of major crisis and upheaval, we need to continue to embrace and support self-determination. And this becomes more and more difficult in our ability to strike a balance and equilibrium between honoring an individual's choice and ensuring their health and safety. It's not easy for us to do that for ourselves, and even more difficult when it involves individuals that require different levels of support and assistance. But still, we need to be very aware of our need to continue to provide and respect self-determination. It's easy when the question is, do you want to play soccer or basketball? Or would you prefer strawberry or vanilla ice cream? But when an individual says that they want to go back to work, or they don't want to wear a mask, or they don't want to stay in the house, or they don't want to go to the doctor, our tendency is to diminish their self-determination. And the question is, how do we navigate that? If you look at the position statements from the ARC, basically, their position statement on self-determination, people with IDD must be able in their personal lives to lead in decision-making and problem-solving about all aspects of their lives and have the supports they want to make decisions. I would like to see that changed and added to, in addition to supports they want to make, they should have the supports they need to make. And that basically is where the DSP comes in. But if you want to have a good navigational tool to how to determine your role in providing self-determination as a DSP, all you have to do is go to the NADSP 9 tenets of the Codes of Ethics. This serves as your roadmap, and basically I position you to promoting physical and emotional well-being. As a DSP, I will commit to promote the emotional, physical, and personal well-being of the people I support. I will encourage growth and recognize the autonomy of those receiving support while being attentive and energetic in reducing the risk of harm. Here's your roadmap. Here are your marching orders from the NADSP. Quote, assist the people I support to prevent illness, avoid unnecessary risk, and understand their options and possible consequences that relate to their physical health, safety, and emotional well-being. That basically is the Eureka statements. And it all falls around the dignity of risk, which you know is the idea that self-determination and the right to take reasonable risks are essential for dignity and self-esteem. And so they should not be impeded by excessively cautious caregivers concerned about their duty of care. This is pretty difficult. Allowing people under care to take risk is often perceived to be in conflict with your duty of care. You need to find a balance between these competing considerations. Overprotection of people with disabilities causes low self-esteem and underachievement because of lowered expectations that come with overprotection. International internalization of low expectations causes the person with a disability to believe that they are less capable than others in similar situations. So how do you do that? You know, again, it's easy on a nice summer day, but basically in the middle of a COVID pandemic crisis, how do we basically balance the right of an individual to basically exercise the three basic needs of all human beings? One is to be able to develop and gain mastery and control of their own lives. People need to have a feeling of control of their own life and goals, and people need to experience a sense of belonging and connection with other people. At the end of the day, as a physician, health and safety basically are paramount to my ideologies. And maybe if I extend myself by being a little paternal to patients that I think are having difficulty making decisions just because of cognitive difficulties, I would rather face the criticism for ignoring someone's self-determination to the point in which I have taken control over to protect them in life and death situations. This is a decision only the individual DSP can make. Hopefully the DSP is working in a culture of their agency, and certainly you can feel the culture of the NADSP in supporting you to making sure that our folks are healthy and safety. But that's not necessarily an easy thing, and I'm not pretending to have the answers, but I do know that there is an excessive rate of paternalism and overprotectivism. And so you basically have to keep your fingers on the pulse of supported decision-making, self-determination to the extent possible. And that probably is where it leads, to the extent possible. So basically, it's a wacky world. And the word wacky means several different things. It can mean absurd, amusing, funny, eccentric, or irrational. It can also mean strange or unusual. Both sides of the meaning of wacky describe what we are experiencing. It's wacky because it's reminiscent of primetime TV game shows, maybe Fear Factor as a comparison, where they put contestants in wacky high-risk situations. And that's what DSPs experience every day during this pandemic. Contestant number one, we have a challenge for you. You will live in a group home and give up your own comforts. You will be in charge of 4 guys 24/7, helping to support their every need and basically providing you with the responsibilities that you also have to manage somehow to do what you do outside for weeks. That they'll all have their routines derailed and sabotaged. They'll have higher levels of anxiety and depression. And basically they are feeling they are being denied what they have loved and enjoyed and doing the things that you have prohibited them from doing it. Things that you have historically encouraged them to do. Dealing with that makes hanging from the top of a bridge look like child's play. And oh, by the way, after you do that successfully for one day, you'll have to do it again and again and again for nobody knows how long. But you do it so well, and you do it without fanfare, without applause, and without celebration. And you do it with dignity, grace, and without seeming to struggle with it. And I, along with my colleagues in the health professions, admire you and are eager to support you in any way we can. So many of you seem to thrive in what has become a real wacky world. So Mark Twain, and Joe is fond of saying, Doc, you can't go wrong with a quote from Mark Twain. And he's right, especially when Twain provides a clever and simple explanation to the situation we presently find ourselves in. Despite the fact that information is constantly on the run, DSPs have resources to help guide them. You have the NADSP, then you have colleagues who have been around the block. Then you have your own experiences and their uncanny ability to get feedback from those they support, even when they can't speak. So keep it up and let us know how we can help you. We need to keep alert, vigilant, and receptive to new information. The best reliance the DSP has is their expertise, their intuition, their code of ethics, and the knowledge of the individuals you support. Keep it up. My hat's off to you. Thank you very much. See you for the next update.
Thanks, Doc. This is Joe Macbeth again. And, as you were talking, I was reflecting on the early days of the pandemic and the first couple of updates that you gave us. We never even really discussed vaccines or herd immunity. It was those early days of the pandemic. And now when we're getting into a direct support professional's duty to help people make informed decisions and balancing that delicate balance of risk versus self-determination. DSPs are in the crosshairs with that in and out of a pandemic, right? I think that's one of the fundamental struggles that DSPs have every day. And I'm so glad that you brought it up. This webinar is going to be available on demand. So if after you see it, please share it with others. And Dr. Rader thank you so much for being our voice on this and helping DSPs understand this nasty pandemic and helping them navigate through it the best that they can. So thank you so much. Take care.
My pleasure.